everyone. I'm Gloria Hall, Editor-in-Chief of Chiropractic Economics, and I will serve as your moderator today. This afternoon's webinar, The True Differentiation Between Decompression Table Technologies, is sponsored by SpineMED and presented by President of SpineMED, Tim Emsky. As the founder and president of SpineMED, Tim has been involved with spinal decompression since 1995 through the initial operation of decompression clinics using a range of technologies, including the VAXD table, the DRS system, and ultimately the SpineMED decompression system. This experience using the range of decompression technology led to the development of SpineMED decompression system in 2001. And now, before I turn it over to Tim, I'd like to go over a few housekeeping items. This program is being recorded, and the webinar will be archived on Chiropractic Economics website, chiroeco.com/webinars. In the next 24 hours, you will receive an email to the recording. Please note there will be time for questions and answers, and you can submit questions throughout the presentation by clicking on the QA icon at the bottom of your screen. Please do not put questions in chat. Please use the QA feature. And now, without further ado, Tim, over to you.
Thank you, Gloria. Let me share my screen and get to our presentation. So, as we know, intervertebral discs are avascular. And being avascular, of course, they don't have a blood supply. And so, like most cells, organs in our body, with a blood supply, the blood supplies nutrition, oxygen, nutrients, and so on into cells. But being that the disc does not have a blood supply per se, it relies on osmotic diffusion, which is a differential in pressure between the internal aspect of the disc and the surrounding bodies. And so for the transfer of oxygen, water, and nutrition into the discs, the pressure changes, of course, on the discs throughout the day. Sitting is one of the worst positions, standing, bending over, and so on. And so the replenishment aspect is when we get our perfect rest, our 8, 10, 12 hours of rest every night. And under ideal circumstances, the difference in pressure between the internal aspect of the disc and the surrounding bodies is only 5 millimeters of mercury. It's very, very slight. And about 70% of that nutritional transfers across the end plates of the disc into the disc nucleus. And as I say, under ideal circumstances, so if whenever there is an injury, we know the body's natural guarding reflex to an injured segment is to guard and protect it. So you'll have muscles and ligaments that will actually fire. And then you'll have no transmission of fluids and nutrients into the disc because there will be actually a higher positive pressure on the disc due to guarding reflex. And some of the primary construct of the disc nucleus to hold the water molecule is proteoglycans. Now, the proteoglycans within the disc nucleus hold the water molecule. And so as the proteoglycans diminish within the disc nucleus, the discs diminish in height, they lose hydration, they dry out, pH values change, hydrostatic pressure changes in the disc, and you end up having with degenerative disc disease. Now, as the discs are subject to loading, different stresses throughout daily activity, torsion, bending, twisting, and again, sitting. Sitting is one of the worst positions of the body in that the pressure within the discs is 2.5 to 3.5 times what it is when we stand. And so throughout the day, we can lose up to 20% of the water content in disc nucleus. And so over time, the discs lose a significant amount of their hydration due to the very inefficient mechanism that the body provides for nutritional transfer. And as I was saying, as disc degenerates, typically lack of oxygen, lack of glucose, change in hydrostatic pressure, pH levels change, and then the death of the proteoglycans, which no longer then hold the water molecules. Now, around the planet, the most common treatments for disc pathology, back pain, and so on are very, very similar. Conservative treatment, NSAIDs, spinal injections, nerve blocks, and then surgery becomes the very last modality used. Now, one of the most common treatments used for years is conventional traction. And many devices now are actually marketed as decompression, but are truly just conventional traction devices. Now, one of the issues with this, and if you speak with a physical therapist who's perhaps as old as I am and has been in the field for a long time, they will be very reluctant to use a conventional traction machine on disc patients, in that they will have had some significantly adverse reactions. Now, some of the leading spine researchers on the planet, Doctors Nackimson, Anderson, and Schultz, actually studied the effects of intradiscal pressure during conventional traction. Now, we would all surmise that if you distract the spine, you're going to unload the discs and reduce intradiscal pressure. What they found, what Nackimson found, is that as they increased the distraction force to the spine, pressure within the disc actually increased. So they actually had a cannula in the L4-5 disc space and measured the pressure changes. And what they found, as they increased the distraction force to the spine, pressure within the disc actually increased. And they found that as a result of reflex muscle contraction. So proprioceptor response in the spine, anytime a force is applied to the body, the neurological response is to counteract that. And so with traction, conventional traction, typically what happens is that conventional traction will trigger proprioceptor response, that neurological response. Erector muscles and ligaments will fire, which then, of course, compresses the discs. It reduces intervertebral space, and the discs then are compressed. Internal pressure will increase, which of course is contrary to disc nutrition. Now, one of the first decompression, actually the first decompression device that was developed by Dr. Alan Dyer, a Canadian physician in the 1980s. He received the first FDA in 1987, and this was the first device that was actually able to demonstrate the ability to apply a distraction force to the spine while bypassing that human neurological response to fire the erector muscles. And so this device, of course, became very popular. Two neurosurgeons in McAllen, Texas, Dr. Ramos and Martin, had two VAX-Ds in their clinic. And because they're neurosurgeons doing a lot of spine work, they would do pre and post MRIs of their VAX-D patients. And they found such marked changes in the disc physiology that they chose to reproduce Nackimson's study and study the effects of the changes in intradiscal pressure during distraction on VAX-D. And what they found, they were actually surprised in speaking with Dr. Ramos. They did not surmise that the significant change that they experienced with decompression on VAX-D, in that they were able to measure a reduction of intradiscal pressure into the negative range. Now, remember, there's always a positive pressure in your disc. So even if you're hanging upside down on an inversion table or hanging your body through chin-ups or something, there's always a positive pressure on the discs. And so they were able to demonstrate a reduction of intradiscal pressure to minus 150 millimeters of mercury. And so when you look at that, by changing the internal aspect, the pressure within the disc to a negative value, creating a vacuum, as it were, in the disc, the diffusion gradient across the end plates of the disc then is enhanced dramatically to more than 200 millimeters of mercury. And because the disc is an enclosed structure, creating a negative pressure within it will gradually draw back disc herniation, disc bulge, and so on. So in addition to the dramatic influx of osmotic diffusion across the end plates of the disc to more than 200 millimeters of mercury. And what they found in their test subjects is that there was kind of a plateau of where increasing tensions, distraction forces between 80 and 100 pounds wasn't really necessary, in that this plateau of negative pressure would gradually flatten out to the minus 150 millimeters of mercury. So they found it wasn't necessary to keep increasing distraction force beyond that 80 or 100 pounds. Now, you can imagine that, so decompression is actually the inverse of what has been going on for decades and decades, where some distraction devices actually cause an increase in intradiscal pressure, which is compression of the discs. And this is why many learned physical therapists are very reluctant to put patients on a conventional traction device, in that they will have had experiences where disc patients have gone into spasm and then it completely blows out the disc herniation, becomes a 911 case and directly to surgical intervention. Now, the goals of the treatment, of course, are to increase intervertebral space through distraction force while bypassing that human neurological response. And therefore, with a small force, you're able to unload individual segments and reduce the pressure within the discs. That promotes, as I was saying, an increase in fluid and nutrient exchange back into the discs, primarily across the end plates of the disc, about 70%, and to promote disc regeneration. And as I was saying, to retract disc bulge, disc herniation, or prolapse. This is the initial VAX-D. We had 6 of these in our clinics in Western Canada. While now you can see that it's quite an aggressive treatment. It's limited in patient suitability and patient scope. So while we would get excellent results in treating lumbar disc herniations, the side effects of treating patients on this device were quite profound. Many disc patients simply couldn't tolerate laying prone. Male patients over 50, 60 years old had trouble hanging onto those hand grips. Females over 40 pounds really couldn't tolerate it. And so, as well, because of the position, we even had young Olympic skiers, 18-year-old Olympians, on this treatment. And after a week of treatment, they couldn't lift their arms high enough to brush their own teeth because of rotator cuff. So, limited patient suitability. And then later in 1997, with the help of Dr. Norm Sheely, a group came out with the DRS system. We changed all our clinics over in the late 1990s to this device because it improved patient suitability, patient comfort, and the results were actually quite a bit better. That group split off and became the AcuSpina and the DRX 9000 in the early 2000s. And so we moved into these devices in our clinics. We had up to 17 of these devices at one time. So we learned what worked and what doesn't work. And what we found is that one of the most limiting factors, not only in clinical time, but in patient experience and the application of force, was the use of conventional nylon harnesses that are used on traction devices. They introduce a significant amount of variability. They're very uncomfortable for patients. They slip off, especially on males, because we don't have pronounced hips. And the application of force is incredibly inefficient in that the distribution of energy has to go through a very elaborate system. And so in our development of SpineMED, we came up with, and this was actually our second idea, in capturing the skeletal structure directly. Now, when you look at the nylon harnesses, the delivery of energy is from an electric motor, either in that tower or in the little box at the end of the table, which is then connected to a seat belt or nylon rope that is then attached to a nylon harness. So when you look at the delivery of energy from that electric motor, it's going through a bunch of nylon through a nylon harness that then has to deliver the energy through the patient's adipose tissue, through the entire torso, through fat, muscle, tissue, even organs, to eventually cause distraction in the spine. And this is why these devices require such high force, in that there's a loss of energy throughout the entire torso and through all of this, the soft material like nylon straps and seatbelts. So with SpineMED, we have this direct capture system that looks like a clamp. Now, all the harnesses, pelvic harnesses and such, actually clamp the entire torso and pelvis. The nylon, or sorry, the pelvic restraints, our patented system, these are metal restraints that are directly connected to the drive mechanism with these steel pins. And it looks like I'm going to have to take off my background, which I can't seem to figure out right now. Nope, it's not going to let me. Sorry. And so with direct capture of the skeletal structure, the delivery of energy on SpineMED is direct to the spine. We bypass that because these metal restraints, again, are directly connected to the drive mechanism. So the delivery of energy is from metal to bone. The restraints are designed to simply rest over top of the iliac crest. They're padded with 5/8 of an inch of gel padding, so they're very, very comfortable. So they don't clamp the pelvis, they simply rest over top. So unlike the old harness style machines, you can see, as I was saying, the delivery of energy then will be from an electric motor in the tower. It'll be then transmitted to a seat belt. The seat belt transmits the energy to a nylon harness, and then that nylon harness has to transmit the energy through the patient's entire torso. And so this is why such high force is required, is because so much loss is experienced and absorbed by the adipose tissue in the patient's torso. Now, with SpineMED, we have direct application of force to the skeletal structure, and we find it's direct to the spine. And so with that efficiency, very little force is required. And more importantly, that the patients actually should not feel a treatment on lumbar treatment. It's that gentle in that we're able to distract the spine with very low force. On SpineMED, we start at 10% of patient body weight. Typically, you don't get above 12%. Sometimes you get to 15%. Versus the older technologies using harnesses, they typically use between 55% and 75% of patient body weight. Again, due to the inefficiencies and distribution of energies throughout the torso. And so there's many aspects. And of course, the question I've had countless times, couldn't count, especially from physical therapists, in that when they're distracting the spine, that how is this different than their traction table? I'm distracting the spine, you're distracting the spine. The ability to bypass the human neurological response is key. And it's not just one aspect. There are several different aspects to it: patient comfort, positioning, the application of force, and then, of course, the control of the force. Now, with SpineMED, we have a biofeedback response system in that there are two computers in the device. There's a primary computer that has all the electronic patient charting, SpineMED proprietary software, and so on. So when you select the patient you wish to treat, you press start, the software will create an algorithm specific to this particular patient, and it will send it to the computer in the table, which then takes over. And the computer in the table then, through this biofeedback loop, it will apply a specific algorithm, and every 2.5 milliseconds, it will verify that algorithm versus the tension being applied to the patient's pelvis at the pelvic restraints. And so this is a very fluid response. We found that we didn't need to adjust tensions every 2.5 milliseconds. It'll sample the tension at the patient's pelvis 8 times. So every 20 milliseconds, the device will adjust if necessary. So SpineMED has been designed to adjust faster than the human neurological response, which is about 50 milliseconds. Now, when you look at the harness style machines, of course, when we came up with SpineMED, all these harness style machines as well, we adjust every 2 milliseconds. But while the electronics may have that ability to adjust every 2 milliseconds, the system, the physical system of the harness style machines, when you look at it, the electronics would then tell the electric motor turn clockwise or turn counterclockwise. So you let more seatbelt out or bring more seatbelt back in. That rate of adjustment is measured in seconds, not milliseconds. You can physically watch that seatbelt slowly move out and slowly move in. And so the ability of these older technologies to adjust tensions is very, very limited. And it's typically between 1 to 2 seconds, not milliseconds. So the other aspect is that targeting specific spinal segments. And what Dr. Norm Shealy found in 1997 using dynamic X-ray, he found that by changing that belt angle relative to the pelvis, he could move the focal point of distraction. And the reason for that is on older devices that just have a flat pull, what you find if you're just doing a flat linear pull on the lumbar spine, the greatest amount of distraction force is at L5S1, and it'll gradually diminish up the spine. So if you're trying to treat the most common level of L4-5, you actually have to overtreat L5S1. And so by changing that seatbelt angle relative to the pelvis, he found that he could move the focal point of distraction so that we could target specific spinal segments. Now, one of the physical aspects of this that's limiting is that the steeper that seatbelt angle is, the more force that's used in the vertical plane. So for instance, if the seatbelt's at 90 degrees, you're not distracting the spine, you're simply lifting the buttock off the table. So there's somewhat of an inefficiency with that system. So with SpineMED, again, we went one step further in that once the patient is captured on the device, we have a patented pelvic tilt, which then places the patient's pelvis into flexion between 0 and 25 degrees so that we can target specific spinal segments. And therefore, 100% of the distraction force is in the horizontal plane. Now, this isn't finite in that if you target L4-5 at 10 degrees, it's not that you're only distracting L4-5, but that is the target segment. There is still distraction at L5-S1s and further up the spine. So it's not that it's finite, but it is focused. Now, with SpineMED, again, the goals, reduce interdiscal pressure. Number one, to promote the influx and diffusion of fluids, nutrients, oxygen, water, prolytes, substrates back into the disc. And then through that hydrostatic action, because it's an enclosed structure, by reduction of interdiscal pressure into the negative range, you can draw back disc herniations and disc bulge gradually. And even severe disc bulge herniation prolapse respond with SpineMED. And now SpineMED is unique, and a lot of people have trouble believing that a device that only uses 10, 12% of body weight for lumbar treatment gets great results. But what we found, and we have clinical evidence, probably the most complete clinical evidence of our clinical results than any device on the planet. You find that with low tensions, our patient suitability window has dramatically improved, where with the high distraction force harness style machines, there are a lot of patients that we simply weren't comfortable treating, the frail, the geriatric, and so on. And so with SpineMED, where a patient doesn't even feel the treatment, the safety aspect of the treatment is paramount. And the oldest patient I'm aware of was treated by a neurosurgeon with our device in Brazil, treated a 96-year-old patient. When I was in California with the DO there, we treated a 94-year-old patient. So with the harness style machines using between 65 and 75% of patient body weight, those particular patients simply would not be suitable for treatment on the harness style machines. So we're able to treat a much wider patient population with SpineMED. And as I was mentioning, we have been published. There's a plethora of clinical research around the planet. Now, one of the unique things about the research done with SpineMED is that SpineMED has had zero input to any of this published research. We haven't sponsored it. We haven't dictated it. We actually have been surprised when it becomes published and our distributors or other colleagues around the world tell us, wow, we published this study. So they're not biased in that we did not pay for them. Now, and you look at some of these pre and post MRIs. These are, of course, SpineMED patients pre and post. Many of these particular disc cases, years ago, when I first got involved in decompression, these would have been immediate surgical consults when we're using the VAX-D or the DRX system. They're just too pronounced. Yet with SpineMED, you can see dramatic changes to huge disc prolapse. What we found with all of this clinical research and our own clinical evidence is that SpineMED has produced between 86% and 93% success rate consistently with both lumbar and cervical patients. The results are quite consistent. In China, the Qingdao Air Force Medicine Center, they had a large case of 118 patients. They had an average treatment sessions of 22, and they were able to demonstrate a 93% success rate in resolving disc herniation, where the herniations were actually resolved. 70 and 75% of the patients were able to work by the last session of treatment. So all sorts of studies from around the world, from probably 20 different countries where the treatments have been researched. Now, this is one of the most profound studies done by a neurosurgeon in Italy, Dr. Filippo Pinedo. And what this is a pre and post MRI study using what's called a degenerate protocol. And what Dr. Pinedo was trying to illustrate was the proteoglycan content within the disc. And so using degenerate protocol, which is 3 times the normal gadolinium contrast medium in the disc, so patients glowed in the dark after the study, specialized software on the MRI and 3.0 Tesla machine, they were able to demonstrate proteoglycan content before and after SpineMED. And so you can see on the left is pre. Now the scale, I forgot to put the scale on this slide. So the scale of proteoglycan, yellow, red, brown is low content proteoglycan, blue is high content proteoglycan, and of course hydration. So you can see here pre-SpineMED on the left-hand side in one of these quadrants, an L5S1, there's significant degeneration in 2 of the quadrants. After SpineMED, restoration of proteoglycan. Now, prior to this, once proteoglycan is diminished in a disc, there is no mechanism that has shown the ability to restore proteoglycan content in the disc. Now, orthopedists will probably look at this and say this is Photoshop because it's impossible. Radiologists will say the same. This is a more pronounced case. You can see on the left, significant degeneration, surprisingly at L1, L2, post-SpineMED, complete restoration of proteoglycans, almost, I would say probably 97%, and throughout the entire lumbar spine. Now, this next case is highly profound in that this is black disc. You look throughout the lumbar spine, especially L1, L2, it's completely dead environment, black disc. After SpineMED, restoration. So this is actually a change from a disc that has a dead environment. Black disc is dead environment. There's nothing living in it. It's dead. And even re-injection of living cells back into this environment results in those cells dying. There's a study, a chondrocyte cellular transplantation that was done by this doctor and actually a doctor in Brazil. And they found that even injecting living cells, living nucleus, into these discs that have severely degenerate, the cells actually die because the environment is dead. And so post-SpineMED, 25 sessions of SpineMED, you can see restoration of proteoglycan. And so that transfer from a dead environment back into a living environment. And again, this has never been demonstrated through any means whatsoever. Protocol with SpineMED is very similar to the other technologies, 30 minutes, completely unattended. Most patients will require between 20 and 25 sessions. Again, we start at 10%. Typically, you don't go above 15% of body weight for lumbar treatment. We gradually increase. And so where SpineMED's different, and this is quite different for many practitioners, especially those that have used other devices, in that the patient should not feel the treatment. And so we can manually increase the tensions being applied to the patient outside what the software recommends. And at some point, the patients will actually feel the treatment. And that's our indication that we are actually causing an inflammatory response at the disc level. And so if a patient is ever sore following the treatment, we reduce tensions. So this is quite different than the harness style machines in that I can tell you when we were trained on them, we were trained that your patients are first going to worsen before they get better. So hopefully after 3 or 4 weeks of treatment, after they've worsened, you're going to gradually see them to start to get better. And that's because you're causing, with the harness machines, with the high tensions, you're causing inflammatory response throughout the entire torso, through all those soft tissues, muscles, ligaments, and organs that have been experienced distraction forces. And so with SpineMED and targeting just disc, and that's what we found, is that if you increase distraction forces beyond the protocol and a patient feels treatment, what they feel is a small area, size of a silver dollar above S1 in the low back, centrally about the belt line, and it becomes warm and tingly. And what we found is that that is the annulus. being irritated from being over distracted. Now, the problem is it's never uncomfortable on SpineMED. You can exceed the protocol dramatically on lumbar treatment, and it's never uncomfortable, but the patient will experience that sensation. And that's our indication you're causing an inflammatory response right at the annulus, which of course we don't want to do. We're trying to reduce inflammation in the spine and speed healing. And so we gradually increase. So the protocol with SpineMed is very subjective. It's based on the patient's response. We never cause discomfort. We always make it comfortable and suitable to the patient subjectively. Cervical is very, very low tensions as well. Typically, we start females at 4 pounds, male 5 or 6 pounds. Females, typically you don't get above between 6 and 11 pounds, depending on their musculature and size. Males, typically 8 to 15 pounds, depending on their size. If you have an NFL football player, of course, they're going to be a little bit higher than the regular. Now, in our clinics, using the high force machines, we found that we would use adjunct modalities. Pre-treatment would use heat, typically the massage tables, the hydro massage that applied heat and massage pre-treatment to allow for better distraction. And then post-treatment, we found ice therapy and interferential to cool down soft tissues and reduce incidence of spasm. With SpineMed, because it's so gentle, we found that those adjunct modalities really aren't necessary, but they can be helpful and they add a little bit more time with your patients because SpineMed is so efficient. You spend 90 seconds setting them up and you spend another 90 seconds taking them off. So there isn't a lot of patient-doctor interaction. Now, indications for the treatment are very similar throughout all the different technologies. Bulging herniated discs, of course, secondary sciatica, radiculopathy, low back pain, which would be mechanical back pain, facet arthrosis, lateral foraminal stenosis, neck pain, and then arm and hand radiculopathy. You'll find that low back pain with facet arthrosis responds very, very quickly. And the degree of disc bulge, disc herniation, there really isn't any limit now with what we can treat with SpineMed that what we found through objective evidence. Again, pre and post MRI, some very dramatic cases of disc prolapse. And you can see there's sequestered fragments on a few of these, and they resolved. That's a whole other discussion about sequestered fragments and how this works. Contraindications are essentially instabilities in the spine. Fractures unhealed, so less than 6 months. Tumors, of course, cancer. Now, gross osteoporosis, if you have a T-score, the cutoff is minus 2.5, which is about 65% bone density. Anything beyond that would be a contraindication. Bilateral pars defects, spina bifida. Hardware implantation. Now, any hardware implantation in the spine is a contraindication as a manufacturer. Now, of course, if you're treating male patient at 22 pounds of force on lumbar spine, the chances of dislodging pedicle screws with that low force is very unlikely. However, due to legal liability, we say that's contraindication. Spondylolisthesis, you can treat a full grade 2, but I would treat them with starting with a little bit lower tension rather than 10%, maybe 8%, 7%. And just be a little more cautious with those patients. And we have treated full grade 2 without any problems. Cauda equina syndrome, of course, contraindication. Pregnancy, more due to liability than anything else. Inflammatory diseases such as RA, rheumatoid arthritis. I have experience treating RA patients, and you touch those people on the shoulder and they flare up. That's one of the biggest issues, is that anything you do with them, they flare up. But we have treated them, even though this is listed as a contraindication, I suppose, in that what you'll find is that once their inflammation settles down after 3, 4, 5 months, then you'll know whether or not the treatment actually had any benefit for them. So overall, what the device is designed to do is non-invasive disc regeneration. We're trying to regenerate the disc and restore hydration and repair all disc pathologies. Now, every disc pathology seems to respond very well with SpineMed. There is no known side effects. First SpineMed was introduced clinically in 2001 in a clinic in Canada. So we've been around for a very long time. And knock on wood, we have never had one adverse reaction. The device has demonstrated an 86 to 93% success rate, and it's completely unattended. And so we looked at efficiency. So in the design of SpineMED, in using these older devices clinically, what we found was that the efficiency of the device within the clinic, so not only clinical efficacy that we were looking to address, but the efficiency, in that in these devices, the harness style machines, because it takes 10 or 12 minutes to set a patient up, and then you have to be near the machine because harnesses slip off, we had to hire new staff. So every time we would bring a new machine into our clinic, we'd have to hire one or two staff, either PT or DCs. And so the financial aspect of bringing a machine in was severely hindered because of that increase in staff costs. And so with SpineMed, one of the other objectives was to make it efficient in the clinic. And so our goal was to make it so that it would fit into a clinic without affecting staff requirements, which is one of our biggest overheads. And so in addition to that, the device, we made it, it's designed from the end user point of view, not from a manufacturer trying to make money on ongoing service and parts and consumables. So we missed the boat on consumables. It has no consumables. It is maintenance free. It requires zero maintenance other than cleaning the cushions. Unlike other devices that have to be cleaned at least every day because they have nylon and aluminum slide rails that have no bearings on them. They have to be cleaned and use special lubricants. SpineMed all uses sealed needle bearings, lifetime with zero friction, zero maintenance. And every device is built to worldwide standards. We're currently in 38 countries around the world. So regardless of the voltage requirements or any of that. Now, as far as efficiency as well, part of the aspect in making the device very, very efficient in the clinic was also in making it kind of idiot-proof and to where anyone in your office can use it. You can hire any of your staff or train any of your staff in the application, putting patients on and doing it. The SpineMed software calculates a protocol. It's all electronic patient charting. So everyone has their own chart. It takes less than 2 minutes to set a patient up, and then it is truly unattended. So in some of the smaller clinics, we find that when there's just one doctor and a receptionist, that it's actually the receptionist that sets the patient up. It's that simple and that fast. So they set the patient up, go back and answer the phone. And so it integrates into a practice seamlessly. We track patients' daily 0 to 10 pain scale, VAS, and also reports and notes. So there's electronic notes built into the device, and that was to eliminate doctors' need to do their notes on the evenings or on weekends. And as we know, sometimes it would be the weekend and doctors try to catch up on their notes. And so to eliminate that and facilitate a much more efficient system, the SpineMed allows an unlimited number of notes, of templates. And what you'll find is you might have 40 or 50 different common notes for decompression patients and how they're responding. And so once you've entered in your customized notes, and the notes are unlimited. They can be one sentence or they can be 25 pages for each of your templates. And so once they're in there, doctor can put your notes in for the day in a second. You simply touch whichever note is applicable for this day, and it's in there in the patient's chart, as well as reports. There's automated reports that can be generated and produced at the touch of a button, either to the incorporated laser printer or exported as a PDF. So if you have a referring physician, an MD, or insurance companies referring a patient, you want to send them a report, it takes a second. Touch a button, it generates a report for you. So again, time savings. So we have two different models of SpineMed for different clinical budgets. The Express, which is a entry-level basic unit, and then the Ultra, which has all of the bells and whistles and the efficiencies that we just discussed. Now, Gloria, would you like to turn it over to
Yes.
Gloria?
Tim,
Okay.
thank you. That was a great presentation. And it's time to move the program over to our special guest speakers.
Okay.
And to kick us off, I'd like to introduce Dr. Christian Karlstrom. A graduate of Life Chiropractic University, Dr. Karlstrom has been practicing in Jupiter, Florida since 1999. Dr. Karlstrom, over to you.
Thank you so much. And am I on there? Can everybody see me?
There you are. Yes.
All right. Beautiful. So thank you so much, Tim. That was a lot of information. I wish you could come and educate my patients every time. That was fantastic. But um,
Yeah.
I have been in practice for 26 years now, and a CBP practitioner along with my wife. And for many years, for about 24 years, obviously we're helping a lot of people. We're a very busy office, between 3 and 350 patient office a week. And I always felt like I could help the majority of my patients with regular chiropractic care and exercises, and of course CBP practice style. But I always felt uncomfortable when somebody came with sciatica or ridiculous symptoms, and I needed an answer. I needed something else instead of referring out to an orthopedic surgeon, or for shots or injections, or even to some clinics down the street that had the other decompression tables. And I got to tell you that in the beginning of my career, I used to refer them out to the other traction and decompression devices, and half the patients came back worse. They wondered why I referred them down there, and it made me feel bad. And the other people, they did better. But I felt like I was not comfortable doing it, and so I stopped doing that. I just went the typical route of referring people to the orthopedic doctors for injection, and hoped that helped them out. So fast forward to about 2 years ago, my good friend of mine, which was up in Washington, D.C., Dr. Mick, he was helping a lot of soccer players, professional soccer players up there, and he was using the SpineMED Ultra table. And he said, you got to get this table to help these disc patients out, and these facet patients that are just chronic and they don't feel comfortable with. So I looked into it, and of course I was a little scared about the cost of the table, and figured out how am I going to do this. And I just said, you know what? I believe you. I trust you, and I'm going to get it. So we got the table, and as it was being shipped down, I started promoting the table. And as soon as we had it in there in my office, I had basically 25 patients lined up to do it out of my own patient volume and my own patient base. And 90, like you said, between 85 and 95% of my patients that started it have had great success. And it's the same thing with my friend. Everyone that has this table had great success. And it's going to be a game changer, because again, it's easy to put him on there. It takes about 90 seconds on and 30 seconds to get him off the table. I'm adjusting my high volume clinic regularly, chiropractic care, and everything else that we offer, massage and red light. And again, it's a standalone treatment, but a lot of them do chiropractic and this table in my office. And the results are phenomenal. It's the easiest thing I implemented in my office in the last 26 years. And it basically took me 4 months to recover the cost of the table. And now it's just a plus, a win-win for me and the patients. And I'm probably gonna have to buy another table here soon. I just need more space, and that's the problem. I'm probably gonna have to expand my office and try to find a spot for it. But it's been fantastic, and I just love everything about it. There's zero side effects, like you said, and I've only had 2 patients that didn't have good results. One was my sister-in-law. She didn't follow my recommendations. And some people think that after 5 or 6 visits, that if they're not 100%, they think it didn't work. So, and that was one other patient. I said, hey, it's typically minimum 20 to 25 sessions, and that's what we sell, 25 session. And then after that, we put them on maintenance. It's typically like once a month, or continue with chiropractic care. So it's been amazing in my office, and I wish I would have known this table was out sooner, but it's been amazing.
Wow.
Dr. Karlstrom, thank you for
Thank
sharing.
you.
Our next speaker is Dr. Greg Lewis, a graduate of Logan University. Dr. Lewis has been in practice in Maryland since 1991. Dr. Lewis, over to you.
Hi there. Can you hear me?
Yeah.
Yes.
Okay, great. Perfect. Well, boy, where do I start? Early on in my practice, I always had a lot of disc patients. I don't know what it is. I'm in Central Maryland. I'm surrounded by farm country, but I'm also in an area that is a bedroom community for both Washington, D.C., as well as Baltimore. So there's long commutes. People spend a lot of time driving in their car after they've spent 8 hours sitting on their tuchus in front of a computer, right? So there's a lot of core strengthening weakness, or core muscle weakness, I should say. and a lot of deconditioning that goes on. So I guess maybe that explains why I've had probably a disproportionate number of disc pathology patients in my career, and I continue to get them to this day. So early on, before SpineMed, I would do chiro on them. I have a flexion distraction table, yada, yada, yada. I could never really get predictable and good results with any of that. And, I became sort of a referral source for the local neurosurgeon. I remember back in the day, just sending him patients right and left because I had a bunch. I found out about SpineMed, and it's an interesting story. A colleague of mine called me up one day and said, "Hey, you got to come check this out." So I went and looked. He created a mystery, so I had to go check it out. So I did, and there was this SpineMed table in his office, and on that table was the CEO of a Baltimore hospital getting cervical decompression on his SpineMed table. I found that out later, right? But I'm sitting there watching this guy getting treatment. He's obviously loving life. It would just blew my mind to just observe this whole thing. And when I thought about, my gosh, this is the CEO of a Baltimore hospital who has access to the best medical care, anywhere. All the spine surgeons, all the PT, all the pain management, all the normal stuff that, medical world does for disc problems. And here this guy is in my friend's office on his SpineMed, and he's privately paying for it. And I said, wow. So I had a huge light bulb go off in my head when I saw that. And so I researched it more, ended up getting my first one. And I have three now. I have three SpineMEDs, and they're all synced together. So any patient can get on any one of them, and they share a brain. So you can pull up the patient's data in any of the machines. And I'm telling you, it's absolutely transformational for the practice. I got the first one and it was full in no time, had to get a second one. And again, I've had a third one now for quite some time. I could use a fourth one. I shouldn't say that to Tim, but I could actually use a fourth one. I'm 66 years old. I just don't want to get any bigger, right? So I'm trying to cruise at this point in my life, working a 4-day work week, and life is good. But the SpineMed, I tell you, it's just everything Tim said is true. When he was reciting the research, I was thinking about my own patients. I'm like, wow, those are my patients. That's exactly what happens with my patients. The lower, less is more, right? With SpineMed, less is more. So you get a bigger bang with less tension. And I have many, many patients in their 80s and 90s that I've had on my SpineMed, and they just lay there and go to sleep and they love it. We tease them and say, if you start snoring, we put you on Instagram. So it's, you walk in my office and there's all three tables. They run all day long. Patients are usually asleep. They're loving life, and our results are phenomenal. I cannot tell you how many patients I've helped avoid back surgery or endless pain management or endless PT. You know the routine, right? So this has become a niche practice. I have a couple of things in my practice that are sort of niche things. This is one of them, and this is absolutely huge. Transformational for the practice. Patients, knock my door down to get here. People know about what I have. It's so unique. There's no competition, right? So once you're on a SpineMed, you'll never go to anything else, and the patients can't get enough of it. They ask me if they can come in, maybe once a month or whatever. Can I come back and get on that machine? Every so often, I want to do it. I want more of it. Of course you can, right? So it's just been quite a ride. I have to tip my hat to Tim for his technology. It's just unbelievable technology. I can't imagine practicing without SpineMed in my practice. And just if you're having any doubts if you're thinking about decompression, there's only one third generation technology system, and that's the SpineMed. The rope and pulley and harness machines, those were popular in the Middle Ages, right? The technology goes back quite a ways. The SpineMed is absolutely revolutionary, and it will completely transform your practice, really like nothing else. So I could go on, but I think I've probably said enough.
Dr. Lewis, thank you so much for sharing. Next up, we have Dr. David King, the founder and clinical director of Ottawa Pain Management and Wellness Clinic. Dr. King has more than 20 years of international experience. Over to you, Dr. King.
Well, can I just say what Dr. Greg said? That sounds that sounds really, really good. Yeah, so well, my background, I've kind of been a mix of everything, and I've been in a world of very high volume practices. The beginning of my career was the I'll call it the typical high volume, 120, 130 patient visits a day type of thing. Um, been in different practices over the years, whether it's been personal injury practices, wellness practices, whatnot. So in my current iteration of practice, it wasn't so much about people that I was seeing that had disc issues that I couldn't help, because I wasn't really attracting those people. It was more along the lines of seeing that there was a need for this um, out in the market, and then looking at what was out there and realizing that, oh, this is probably not so great. So then I started to investigate and thought, well, maybe I'll go down the road of having a practice with decompression. We had some niches in our practice, and I thought, okay, well, this would probably be a good one. So of course, I don't know where to start. I don't know, one bed from another. So I started to have a look around, and I I actually ended up in Dr. Karlstrom's office one weekend last year, early last year, after just after he had gotten his SpineMED, and I got on it, and I thought, okay, well, this is not what I was expecting. So he let his excitement spill over onto me. I did have some questions that I had asked other chiropractors who had some of the other the tower tables, the AcuSpine, the DRX, to get their kind of experience, their feedback on what was going on. And then it was, I think what sold me on it was a conversation I had with Dr. Tager, Aubrey, and, looking through all the research and things like that, it just made sense to me. So, yeah, bringing it into the practice. To this day, I haven't advertised. I didn't advertise to start with. I still don't advertise. People just come. And the reality of it is that when you start to really look at things, yes, the fantastic results with disc patients, but I think one of the things that gets overlooked is these people with the facet pain, and just the degenerative spines. I mean, to say that they respond quickly is really kind of an understatement. I, there's a very large number of people I've had who are well into their 70s or 80s, and this is really degenerative arthritis, mostly in the facets, with, of course, compressive, we call it the degenerative spine.
Mhm.
And 1 to 2 sessions, and they get up and they're just like, oh, wow, I feel so good. I feel so good. And they just can't get enough. So don't overlook that part of it. But yeah, as far as where this sits, where in the market with the other tables, I just spent a weekend or a day last Saturday. I just spent it in a room with probably 100 other chiropractors, the vast majority of whom have AcuSpine as their DRXs. And every time they ask me what table I have, and I tell them, and they look at me like I have 10 heads. And I explain to them why I use this table, the simplicity of it, and how it just makes good mechanical and neurological sense. Um, and they still can't seem to get their head around it. I think there's just a lot of people who are just stuck in their ways, and I think that's human nature. But if uh, if anybody is considering decompression, then you have to look at the SpineMED. As far as I'm concerned, I haven't seen anything else that comes close to it. And Dr. Lewis talks about needing another table, and Dr. Karlstrom talks about it too. And it's, I have one and I could have two. I don't have space. I'm actually in the process of right now of trying to negotiate a move to get more space, because I want to get another one. So yeah, that's a little bit about my story. I'll leave it there.
All right, Dr. King, thank you so much for sharing. Our final speaker, Dr. Louis Pierre Brunel, Dr. Brunel has been practicing for nearly 25 years and is a graduate of Logan College of Chiropractic. Dr. Brunel, over to you.
Well, I guess my story is a little different in the sense that back 20 some years ago, about 20 years ago, I suffered from 2 disc herniations myself. And I like Dr. Karlstrom, I think, sorry if I got the name wrong, but I'm a CBP practitioner also, and it's something that I absolutely love to do. But physically, I just wasn't able to anymore. And I had young children back then. And really, my life came to a complete halt for about a year. Literally, I was adjusting patients sitting on a stool. I couldn't do anything anymore. And a local doctor had a SpineMED table, I think right in the first generations of SpineMED. And it is what literally gave me my life back. And so for me, I experienced it, and it was life-changing in the sense that I'm a trail runner. And it gave me my chance to get back into running. I've done marathons since and everything like that. And so it was just for me a no-brainer to say, okay, if this is something that's excellent for me, then it's going to be absolutely life-changing for my patients too. So I decided to change kind of my expertise. Part of my heart will always be CBP, so I still do practice CBP, but on a smaller level now because I've transformed my practice more into decompression. And what's amazing is my dad, he's 86 years old, and he's a chiropractor, and he still practices today. And I'd say thanks to SpineMed that he's still able to practice today, because as a chiropractor, a lot of you know that, I remember being young, the older crowd would always tell me, oh, you'll wait later, you'll have shoulder issues and low back issues and this and that. And what I've kind of realized is that decompression is what's going to allow me to, I hope, one day be like my dad, because I love what I do. I don't see myself retiring one day. And so at 52 now, this is something that's going to definitely extend my career. And the results are just absolutely amazing in the sense that the patients just are transformed with the SpineMed technology. And at one point, Tim knows, I think my dad and I were my dad especially, we were the godfathers of spinal decompression in Quebec, in the sense we had 14 tables, I think, between the two of us. So I sold a few of my other clinics and decided to just focus on one. I have 4 decompression tables that I have one staff only that manages all 4 of the tables, and her job throughout the day is just to install and uninstall the patients. And I mean, it's great. The patients sleep on it. They love it. What surprises me too is how far patients will come to be able to use technology like SpineMed. I mean, they travel an hour and a half for their care, and they'll come 3-4 times a week for that, for our protocols. And it changed my life, and I see it change patients' lives on a regular basis. And like I said, for me, what's amazing too is it's going to help me to prolong my career to years and years and years to come, to help me do something that I absolutely love. So I think all the other speakers kind of said so many good things too. So I don't think there's that much more that I can add, but that I'd say it's just life transforming as far as technology goes.
Fantastic.
Wonderful.
Thank
Thank you
you.
for sharing, Dr. Brunel. Now, I do see we have some questions coming in, so we'll go ahead and get started with the Q&A.
Okay.
All right. First question. What other therapies are people combining with decompression, like class 4 laser, ice, etc.? And what protocols before or after care, also supplements used for healing as well?
That's and I'm probably going to pass this off. As I was saying, that we used a different number of modalities adjunct to SpineMed, and especially on the older technologies. Now, this becomes a very personal aspect to the doctor and what they do. And perhaps we can go through what our 4 doctors use clinically now. And I think most of them use laser, actually. So why don't we go ahead, Dr. Brunel? You want to kick off with what you use adjunct modality?
We used to do we used to do what you said in the beginning. We used to do the heat protocol beforehand and then the ice afterwards. And then when COVID hit, because of, you know, wanting to get patients kind of in and out quicker, we stopped that. And I'll be very honest with everybody, it made no difference in the sense that we actually, patients are getting the same good results. So the only thing that we do in our protocols that we've noticed is we have actually patients wear a lumbar support belt for what we call our intensive part of our care, just because what we've noticed is because it's so efficient as far as treatment goes, that the muscles throughout the spine release at a very quick rate. So the spasms that they had, the tightness that they had, it loosens up. So because of that, the low back does become a little bit more fragile to patients in the beginning. Plus, it gives us kind of a little bit more of a control on what patients are doing outside of the clinic during that protocol. So, you know, during like say a 6-week period, we'll have them wear belts 6 to 8 hours a day. And then ice 3 times a day, and that's it. And then once we're done with the intensive part and we get into more of the stabilization phases of our care, then we have them take off the belt and not wear it anymore so that the muscles don't become, you know, weaker or anything like that. And then we just, sorry, have them ice about once a week. Once a day towards the end of the day in the evening for a couple more weeks, and that's it. And then we put them on a regular maintenance care.
Perfect. Dr. Lewis, do you want to chime in with your adjunct modalities?
Sure. So this has been put together over a number of years. I've had SpineMED in my office, 20 some years, thereabouts. I mean, a long, long time. In fact, I have the older models, the Pro model, which is no longer made, but it's been upgraded. Tim has upgraded my systems and they're just cruising right along. SpineMEDs last forever. I'm telling you, they never break down. They're just amazing pieces of equipment, medical devices. So with any disc patient, you're going to have core muscle weakness typically. And there's also going to be some biomechanical issues as well, right? So I find that combining chiro care, chiro adjusting, you know, appropriately with core activation and core strengthening, along with the SpineMED. And then particularly early on, but even throughout the program, I use a Sumis Class 4 laser, and I also have a PEMF device. And so all of those things come in synergistically and they work together. And I think you get, the SpineMED is the cornerstone. If you don't have the SpineMED, you're not going to get the results. But if you have the SpineMED and then you add a little bit of frosting on the cake with some of these other things, I think you can actually enhance the outcomes. And we just, my gosh, I think, you know, maybe I'm crazy, but I think I'm at 98. I'd have to stop and try to remember the last time I had a patient that did not do very well, right? I mean, it's very, very rare. I mean, we're probably 98, 99%. I know that sounds incredible and unbelievable, but I'm just telling you, I'd have to think really hard to remember one that did not just extremely do very, very well and just fully restore. Within 6 weeks, I've had huge fragments, you know, sequestered fragments get sucked back in. It's just amazing. I mean, spinal stenosis, facet syndrome, all sorts of disc pathologies, you know, bulges, protrusions, prolapses, etc. They just all get better. And it's just amazing. And you're using these extremely low tensions. That's the thing that's so mind-blowing. When the patient asks me, doctor, is this thing turned on? Right? Which they do, right? So I have this little talk, my little SpineMED talk. Whenever a new patient starts on the SpineMED, I always go over and I stand there and I give them the talk and I say, okay, now this is decompression, this is not traction. And I walk them through explaining why they're not really feeling it and how superior this technology is to all the other stuff out there that's going to be, you know, pulling and yanking on them. This is very subtle, flies under the radar, bypasses the stretch receptors, no muscle reaction. Patients just absolutely love life. If you don't have a SpineMED in your practice, you are completely missing the boat, I have to tell you. And you know what? Once you get one, you're going to get more than one because you got to have more than one. I'm telling you. All right, I'll be quiet. Go ahead, guys.
All right. Dr. Karlstrom, are you
Yep.
there still?
I am here. Can you hear me?
Perfect. Yeah, sure.
Yeah.
Do you want to share what adjunct modalities you use, if any?
Yes, that would be great. The number one thing, obviously, is I like this table because it can be a standalone treatment. So if people come into our office from an ad or referred in for just the decompression, that's all we do. About halfway through, I do a post exam or a progress exam. And if I feel like they can benefit from other services, I try to introduce them to chiropractic or massage or acupuncture that we also have, or cold laser. So we have other options as well to enhance the healing if I feel like they're not responding as quickly as I would like. But the majority of people don't need anything else. My existing chiropractic patients continue with chiropractic care along with the table and everything else that they do in my office. I would say for the first 2 weeks, I only do the table with some ice afterwards, and tell them to limit some of the, we get a lot of golfers here. I mean, we're in golf mecca down in Jupiter. So I see a lot of professional golfers and I see a lot of amateur golfers that think they're professional and very deconditioned spine. So I have to tell them to maybe slow down the golfing for a week or two, which is like the sin of all sins to tell them. But typically they listen because they're in bad shape. So that's pretty much it. So I try to incorporate chiropractic, but many times they're just doing so good with the table. And then we also have the red light pad that we put on top of the table, along with the infrared heat that's already in your table. So they get the heat from the infrared heat that maybe you didn't mention, which is amazing, so that it actually heats the tissues while they're doing the decompression. And so that's what we do. But typically for 2 weeks, I typically just do the table to make sure there's no contraindications. And I know that the table is working on its own.
Excellent. Thanks. Dr. King, anything to add?
Yeah, it's interesting how it can be a standalone treatment. In my practice, I adjust to everybody who goes to the SpineMED, so I'm always incorporating that. I'm a low force adjuster, so I'm more of a I'm less of a structural move the bone and more of a neuromuscular trigger the response. So it's getting them adjusted, doing the SpineMED. As far as adjuncts other than that, I do use something called magnetotransduction therapy. It's not PMF. It's a very, very high frequency compared to PMF. But I will use that simply because we've got the research now that does a really fantastic job of activating a lot of the cellular processes for building no bone and rebuilding cartilage and rebuilding other connective tissues. So, and also brings down the inflammation and can bring down the pain too. So, and that's a standalone. That's an unattended thing as well. So, it works very well where we can bring them off the SpineMED, put them somewhere else, and I can push a button and walk away there and let them do their thing for 10 minutes. And I'll say this as well. The reason that I use that is, Dr. Brunel talked about disc injury. That's also one of the reasons that I ended up bringing the SpineMED in, because I had many years ago, I had an L4. This was when I was in Australia, and it took me a while to recover from that. But in more recent times, I actually had the distinct joy and privilege of experiencing an L1 and an L2 herniation at the same time. It's actually the SpineMED that totally resolved all my symptoms. So I was on the bed before I got on this call. on this webinar. I said I was late due to traffic, but I was in traffic because I left the office too late. So yeah, that's how we usually do things.
That's
All right.
great.
We can move on to another question.
Okay.
Also, what is the setup for short patients on the table? They don't love the giant triangle. So what is the best placement for capture of the pull on the table for them and all patients?
It's the same whether you have a short or a tall patient. The distance between the top of the iliac crest and the lower margin of the rib cage varies slightly. But with SpineMed, again, the direct capture on top of the pelvis is the same for everyone, regardless of height. So even if you have a 7-foot patient, their legs simply hang off the end of the table. I hope I'm answering this to their satisfaction, but there's really no difference. Some of the bigger differences would be in very small patients. So we're in countries like Vietnam, where some of the females might be 76, 78 pounds. And so they're very, very small, where with harnesses, when we tried to treat patients like that on the harness machines, they would just slip off. But with SpineMed, you capture them perfectly. These restraints capture any patient. I've even put on, I hate to say it, a 525-pound patient on SpineMed, and these restraints bind the pelvis. They just they work on virtually any patient. And so that's the setup. And it's very, very simple with a wide range of patients, and not only size, but actual physical attributes as well.
I think Tim too, sorry to interrupt.
No,
I think
please
part of the question too was about the with the smaller legs, you know, putting the triangle underneath the knee.
Oh, the
Yeah,
cushion, the knee bolster.
yeah.
Yeah, well, and they may be talking about an Express, which isn't adjustable. So one of our patents is that the knee bolster on the Ultra and the Professional is adjustable. So it's 50, 60, 70 degrees in that it has different leg heights, I think from 9 to 12 inches so you can accommodate different leg lengths. And so we do have that accommodation where you simply rotate it. But on the Express, because it's a lower entry model, it doesn't have the adjustable bolster. It's just got a fixed bolster. Maybe I'm answering it, hopefully.
Yeah, and
Right.
I don't know if you agree with this, but one of the things we've done with a few of our really shorter patients too is we've used kind of a big pillow that we've kind of put underneath the knees, but we try not to do that very often. But
Well,
Right.
one of the things that we have done, because my mother-in-law is very, very tiny, and so when her legs go over the triangle, even on the lowest setting, the feet hang. So what
Okay.
I've actually done is I've just taken one of the massage bolsters that we have and just slid it under her feet so that they're not dangling anymore, but they're still positioned over the triangle.
Perfect.
All right, thank you. Another question, any universal advertising offered, or how do you get new clients?
Well, and this has changed. So we used to be on the clinical side, and so we marketed actually all across Canada for years. So we had a plethora of marketing material that we also include with the SpineMed table, all the way from print ads to websites to television commercials. Now, the world has changed, and I would suggest that even in different geographical areas, the marketing will have changed, will be different. These 4 doctors probably use different forms of marketing. But social media seems to be at the top of the list as far as generating patient flow. From all the doctors that I talked to over the years, that seems to be the new paradigm, that it's social media. It's Facebook, it's Twitter, it's all of that stuff. Any other comments, doctors?
Yeah, I can jump in here. I've been doing this a long, long time, right? And my own reality is I think most patients with back or neck pain, most of them have a disc component involved in their pain. Now, not everybody, of course, but I think more often than not, there is disc involvement than what we've kind of believed historically. And I can tell you, any chiropractic practice, any standard chiropractic practice, I would argue that probably 50 to 60 to 70% of the new patients that walk in the door are probably SpineMed candidates. Now, it's up to the doctor, whether they want to recommend it, and depends on the clinical findings and the history and all of that. But I think any chiropractic automatically has SpineMed candidates walking in the door as new patients. So there's that, right? Because remember, degenerative disc disease, Facet syndrome, et cetera, et cetera. You saw the list when Tim was walking through it. Almost everyone could be a candidate, I could argue. So again, it's just a matter of patient selection and who you want to recommend it to. So there's that. So the first place to look is in your existing practice. That's the first place to look. Because I'm telling you, there are patients there right now that probably need it and probably should be getting it. That's my opinion. And then what I've also found from an external marketing standpoint is I always promote the condition, and then that brings them in, sciatica, pain down the arm, pain down the leg, pinched nerve, those kinds of terms. If you sort of describe the symptom that a spine med would be appropriate for, that connects with people and they go, oh my God, I've got that. I'm going to call that number. And then the next thing you know, they're in your office. What Tim said also is very true. We have a very robust social media and Google. We get a ton of new patients from Google. I have a really, really good SEO guy, SEO. If you don't have a really good SEO person, you need one. And we get a ton of patient Google reviews. We probably get 1 or 2 Google reviews a week, and they're all just, you need a tissue box. If you read them, you need a tissue box. I mean, they're just quite profound. The heartfelt appreciation and the love that we get from our patients because we just literally changed their lives with this technology. So those are the biggies. But we do everything. We have a billboard. We get patients from our billboard. You got to change it up regularly, right? And we do direct mail also. So we have a postcard thing that goes out. We do our entire zip code once a month. So we have a multimodal reach, if you will, and from marketing. Remember, marketing is nothing more than communicating, right? Communication with your public, right? You have the public's out there. If you don't talk to them on a regular basis, they forget that you exist. I use the example of Coca-Cola. Everybody knows what Coca-Cola is, and yet they spend billions every year marketing their product. That tells you all you need to know. People have short attention spans. They don't remember. You have to continue to talk to them and continue to communicate. So that's really what it's about. And then patient referrals. I mean, my God, I cannot tell you how many SpineMed patient referrals I get internally. Patients come in, we change their life. They bring their whole family in. They bring their uncle and their brother and their cousin, and it just goes on and on and on. Like I said, I need that 4th table, right?
All right. Thank you, Dr. Lewis. We have one final question. Have you had anyone with a disc bulge who is super petite and complains of right hip pain before and still after the whole treatment protocol? She did great, but the hip pain is still there. Are we missing something that needs further imaging?
I can
Any
jump in
advice
on
would be
that.
helpful. Okay.
I can jump in on that. So I would want to make sure that she's talking about the actual hip joint, that is the ball and socket, and not the SI joint. A lot of times, particularly with patients, now this is, the question, particularly with patients, when they say, doc, my hip, I got pain in my hip, and they're holding their buttock, right, which is normally coming from the lumbar spine, right? The hip joint is in the groin, right? The actual hip joint, the ball and socket is in the groin. So I would want to clarify, okay, where exactly is the pain? Is it SI or buttock region?
It's SI joint.
SI joint.
Yep.
All right, fair enough. Well, so I was going to say if it was the hip joint, obviously hip X-rays would be the next thing to do, right? But SI joint, we don't really see that here in our practice. I don't have people coming off the SpineMed with sacroiliac pain. I don't have that. It's
She said it was
possible
before.
it's possible the tensions are a little too high. Tim can probably speak to this. If they're
Well,
coming off and go ahead, Tim.
she actually said she had the SI joint pain before treatment and also after. So pain in the hip. So it sounds like it might be SI that didn't resolve. Of course, it's not going to resolve through SpineMed. It'll require different treatment. But if I'm correct, she said that it was before and then after it's still there.
I've seen this in I've seen this in practice where you'll have a patient who has a disc issue that can be dealt with on the spine med, and they have a separate sacroiliac joint issue that
Yeah.
needs to be taken care of otherwise. And in those patients, I will use the spine med for the decompression. And then if the SI joint, it may respond to chiropractic, it may respond to SOT. I've had some where we will use focused shockwave therapy to treat the SI joint. But we've got 2 things. There's an apple and an orange there that needs to be taken care of.
Agreed.
Yeah. 100%. Okay.
Thank you, everyone. At this time, I would like to thank our sponsor, SpineMED, and Tim Emsky for today's webinar. And a big thank you to our guest speakers, Dr.
Yeah.
Karlstrom, Dr. Lewis, Dr. King, and Dr. Brunel. Remember, this webinar has been recorded and will be available on chiroeco.com/webinars. Thank you for attending, and we look forward to seeing you next time. Have a great night,
Thank you.
everybody.
Thanks, Gloria. Thanks, gentlemen. Much appreciated.
Thank
Thank you.
you.